Assalamualaikum warahmatullahi wabarakatuh. Salam Malaysia Madani, salam Universiti Watan, and very good afternoon to Associate Prof. Khaldun, Ismail, our panelists, Dr. Hassan Adam, Dr. Vanessa Uyen, Dr. JD Comandante, clinicians, and fellow medical students. My name is Amirul, and along with me, my friend Zurin. We are final year medical students in Universiti Kebangsaan Malaysia. Will be the moderator for today's webinar. Welcome to the third series of the Clinical Toxinology webinar organized by Emergency Department of Hospital Chancellor Tuanku Mukhris in collaboration with the Malaysian Society on Toxinology, Remote Envenomation Consultancy Service, College of Emergency Physician Special Interest Group in Clinical Toxinology, Malaysian Biodiversity Information System, University Science Malaysia National Poison Centre. In this webinar and forum, we aim to explore the topic of clinical toxinology. Is it relevant to medical students? Just some housekeeping rules before we begin. Feel free to ask questions in the chat box below. Question will be addressed by the moderators at the end of every case. There will be feedback form at the end of this webinar to receive the certificate of participation. To deliver our welcoming remark, please join me in welcoming Dr. Nik Azlan Nik Muhammad. Dr. Nik Azlan graduated with Bachelor of Medicine, Bachelor of Surgery, and Bachelor of Obstetrics from National University of Ireland at 2001. He completed internship in Ireland and worked in PPUKM since 2003. Joined Emergency Department and completed Masters in Emergency at 2010. He in charge in Part 1 Masters, Medical Student Rotation, Pre-Hospital Care, Service and Medical Standby. Currently, he is a consultant of emergency medicine in the Emergency Department, PPUKM. Without further ado, Dr. Nik, mic is yours.
Assalamualaikum and a very good afternoon. Thank you very much for that introduction. So as an introduction, I just like to thank all the panelists and professors and doctors and also students for being able to join this wonderful and very exciting forum webinar, which actually it's something I would say kind of new to the to the medical attachment emergency. Relatively new because I think when it's the first start out to have medical attachment students in emergency, we wouldn't have any toxinology thing. But it's actually, I mean, this is the only time where students will actually learn about toxins, and you won't get this in any other attachments. I mean, like emergency, you will get a lot of things that you don't get in the other attachments, like pre-hospital or disaster or it's actually well, you get also the basic CPR, but this toxinology, I mean, it's actually very specific to this emergency, and this is the only time you will be able to learn it. And a very special thanks to Professor Khaldun and also other colleagues invited. We invited actually to share this experience. And the topic actually, well, if it's relevant, yes, of course it's relevant. I don't think, even though after you complete your medical degree and you are going to housemanship, or you wouldn't get to learn these things. Unless if you join emergency, even emergency, then you specialize in toxinology, then you will relearn it again. But take this best, and actually these things you will see in daily life actually, especially in this area, you will see a lot of envenomation or toxin kind of animals, snakes, and the things you will see. Well, you will see even in your daily life outside hospital. It's actually very good to know this knowledge, and I'd like to this is my welcome remark, and I hope of you get gain a good knowledge from this webinar. Thank you very much.
Thank you, Dr. Nick, for the welcoming remarks. So now we'd like to move on to the...
So, ladies and gentlemen, joining us today, we are very grateful to have the panel of experts. First is Dr. Hassan Adam. He has been an emergency medicine specialist in Ripas Hospital, Brunei since 2013. He was an emergency resident at Emergency Department of University Malaya. He graduated from Al Jazeera University, Sudan, and proceeded to complete his master in emergency medicine at Hospital Malaya, Malaysia. He also completed fellowship phase MTOX in 2018 in India. He has special interest in all aspects of toxinology. Next is Dr. Vanessa Uyen. She is currently a consultant at Chori Hospital, Ho Chi Minh City, Vietnam, in toxic disease since October 2023. She is interested in medical toxicology and learned medical toxicology by herself when she was a medical student. She got scholarship for 3 months for Taiwan International Healthcare Training Center Fellowship in 2014 and won Taiwan ICDF scholarship for her 3 years master degree. She also has many teaching experience, include being a lecturer of medical toxicology, acute and chronic poisoning at Churi Hospital, Vietnam for 5 years. Basically, her distinguished ability include learning, studying, and doing research on toxic diseases. Since 2000, specialty in medical toxicology, individual toxic agent screening for toxic disease, chronic poisoning, occupational toxicology, environmental toxicology, nutritional toxicology, and natural toxin. Finally, last but not least, is our Dr. J.D. Comandante. He is currently an emergency medicine and head sections of toxicology in Hospital Ang Makati. He started his undergraduate study in University of Philippines and finished his specialty training in emergency medicine in 2018. He then continued his fellowship training in clinical and occupational toxicology in National Poison Management and Control Center, Philippine General Hospital. His research of interest are in emergency medicine, medical toxicology, clinical toxicology, emergency medical services or pre-hospital care, and also disaster medicine. He is also a founding member of Philippine Toxinology Society Incorporated. A warm welcome to our panelists. Thank you for joining us today.
Before we begin the discussion, we would like to present our findings for pre-webinar survey to determine. It is a survey to determine the level of awareness regarding this topic among medical students. So as we can see here, majority of our medical students are aware regarding what this clinical toxicology is all about. And they're also aware of the appropriateness of clinical toxinology and the appropriate safety regarding toxin injuries. However, majority are neutral regarding the knowledge about appropriate safety and health regarding toxin injuries.
So next up, I will present about information about toxinology and clinical toxinology. So basically, toxinology, by the definition, is the scientific study of substances produced by living organisms, either delivered as venom, residing within tissues of animals, plants, mushrooms, and bacteria, which may harm target organisms. While clinical toxinology is an area of specialist medical expertise dealing with envenoming and poisoning caused by animals, plants, mushrooms, and bacteria. So, to my fellow friends, toxinology and toxicology is actually a different things. By the definitions, the toxicology is the scientific study of all types of toxic substances, including synthetic chemicals like industrial pollutants, pharmaceuticals, and also pesticides, and its naturally occurring substances. It encompasses the detections, effects, and mechanisms of actions of the toxic substances. So there is a difference between envenomations and also poisoning. So envenomations is exposure to venom containing toxins, which results in from venomous animals, while poisoning is an administration of a poison which containing natural toxins inside one body via swallowing, inhalations, or absorptions through the skin. So to make things easy, if you bite it and you die, it's a poisonous. But if it bites you and you die, it's venomous. So there is a several clinical toxinology in Malaysia. It includes Malaysian Society on Toxinology, Remote Evaluations Consultancy Service, Clinical Toxinology, College of Emergency Physicians, Malaysian Biodiversity Information Systems, and last but not least, University Science Malaysia National Poison Center. So there are few of importance of clinical toxinology for medical students. First, because it is common in Malaysia. Second is because it is needed for emergency care. And last but not least, it is very life-threatening to patients who ingest the toxins.
Okay, next up we'll have a 5-case presentation. After each case, we will invite the panelists for some discussion, followed by a short Q&A session, if any, in the chat box. And the audience can drop their queries in the chat box during each case presentation. So now, let's start with our first case. It is a case of 85-year-old Malay male was bitten by snake on bilateral arm. The incident happened at patient's backyard in Kedah. Time of incident, 9 in the morning. Patient was clearing grass at the backyard. It was near to field and rubber estate. Initially, he hit the snake in intention to chase it away. However, he was bitten on the right and bitten again over the left arm. The snake remains there after biting the patient. The snake was thrown away by the patient into the nearby area, but no picture was taken. However, the patient identified the snake as Malayan pit viper from the gallery. Patient claimed that his children massaged around the snake bite area. Pain score was 5/10. Later, he went to GP, general practitioner, and was referred to ED and arrived at 12 p.m. on the same day. Further history from relative, patient likely had dementia for quite some time. He saw the snake on the ground and approached it. Next. So this is on examination. He was alert, pink, not tachypneic. Vital sign was stable, BP 119/71, pulse rate 75, temperature normal, SpO2 95% under room air. As we can see here in the picture, on the left hand and the forearm, there was multiple puncture wound with active bleeding, grossly swollen hand till the elbow, and extensive ecchymosis. On the right hand, there were multiple puncture wounds with active bleeding and ecchymosis, grossly swollen hand till proximal forearm. So next picture, we have a more clearer picture. We can see here on the right hand. Hope we can appreciate the findings in this case of the right hand and the left hand. So we like to leave to the panelists to discuss regarding the history and the clinical examination at this point.
Anybody like to comment first? What do you think? It looks bad, right?
Good afternoon, everyone.
Afternoon. Go ahead.
Thank you for having us, and thank you to Dr. Khaldun and his team, and our fellow panelists, and Dr. Nick Aslan, and the rest of our team. First of all, yes, it looks bad. It really looks bad. If we look into the timeline from 9 a.m. to the time the patient arrived to the ED is like just few hours. And yet within
Can we
these
see
few
the
hours,
slide? Can we see the slide? The history slide?
Yeah, he was bitten at 9.
And
yeah, just few hours. But yet the involvement is like quite drastic. And of course, from the history-wise, he might be bitten a few times. We don't know whether it's the same snake or maybe another snake. We are not sure, but definitely, he was bitten a few times. So from the picture-wise, to me, it looks like something like kind of myotoxic, a kind of envenomation. Yes, there is a pain score, probably around 5. So really, I'm not quite sure to pinpoint exactly what might be the species, but in a general context, I'm thinking might be myotoxic kind of envenomation. But
Okay.
yeah.
All right. JD, what do you think? I know it's not maybe not present in the Philippines, but what do you think just from the history? Anything that you think you want to ask more or find out more about this case?
Well, first of all, thank you for the organizers, Dr. Khaldun, and our MCs, Master of Ceremonies here. Actually, definitely, the patient really had some type of envenomation. But one of my questions here is that will the patient have systemic signs of envenomation, given that there was actually uh, uh, immediate progression of the swelling from 9 to almost 3 hours, you know, from the time he arrived at the emergency department. My next question is that what would be the parameters that had been already been taken? So based on the history alone, we saw that the pain score, I think at the first consult, was 5/10. So we are actually asking what would be the next, is the pain increasing? So we have, you know, our progression that we monitor. And I think, yeah.
Yeah, maybe Vanessa, anything this definitely present in Vietnam, this species. What do you think? What's the first thing comes to your mind? Vanessa?
Yeah, because in the history they say that so the patient identified the snake and Malayan pit viper from the gallery. So if we confirm that it's that kind of snake by the patient, but I'm considered because on the picture of the patient, I don't see any blister, right? Because
not yet.
Not yet. Yeah, because usually when my patient come, it will be severe swollen and many, I mean the multiple blister on the
you can see
like
some
that.
early.
But I see he is look like severe, very severe already. Also the color of the skin change.
Yes, you can see some early signs of the blister forming as well.
Yeah, but so just his.
Okay, all right. So just to put things into context, the gentleman is elderly, 85 years old. Second, he wasn't as fast to remove from the strike from the snake, so he get multiple bites on both hands. And then on top of that, this species doesn't run away; it just stays there. So this is very typical feature for a Malayan pit viper, different from the other pit vipers that we find. They will strike and they will run away from threat. But Malayan pit viper is they strike and they just stay where they are. Okay, that's another thing. And then the coloration is very typical. It's on the ground brownish color, very difficult to see, and quite easily to identify. You have already seen it. So we think that the patient probably, because he killed the snake, right? So he definitely have a good look at the snake. So we feel that it's most likely is a Malayan pit viper, even though we do not have a picture of it. But from the description, from the features that he pointed out, and also he himself pointed out to the gallery that we have, it's most likely Malayan pit viper. The feature is very typical as well from Malayan pit viper, can be very severe. As you can see here, early swelling, painful, starting to have blister, and the blister is hemorrhagic as well. You can see that, and bleeding from the puncture wounds. So there's typical signs of hematotoxicity. There's probably some features of myotoxic, or not really myotoxic, some features of cytotoxic, but that is not really yet evident here. So I agree, but the one more feature in the history, if you notice, they massage they massage the bite area, they massage the limb, so that doesn't really help, and that's probably why he present here quite bad, because they help spread the venom locally, so that causes more tissue necrosis or tissue injury there. Okay. So whether that delayed the transfer or something else, we're not sure. But they went to GP first, which they cannot do much, I think, in the GP. That's why he transferred to the hospital emergency department. Okay, so I agree with JD. We need to see the progression, right? You were saying progression of the sign symptoms, progression of the vital signs, progression also in terms of laboratory investigations. Maybe our moderators can highlight us a bit more in the findings.
Sure. Let's get into the investigation. So at this point of the in the ED, the impression at that time was to identify snake bite, probably Calolesema rhodostoma Olympic viper at bilateral hand forearms with local and systemic envenoming. Management at that time was to give a 2 dose of the CRAV, IV tramadol 50 mg, IV Moxolon 10 mg, RPP and PSP hourly, and to do FBC, COAC, and CK6 hourly. So let's have a look into the investigation.
I think the antivenom is not given 2 doses at the same time. It's actually one dose after then the other after certain period of observation, right?
So in this case, we can see in the lab blood investigation, serial blood investigation, we can see the total white cell count high, the hemoglobin is low, platelet is low, and the PT and FPDT prolonged PT and FPDT in this case, and LDH also high.
Is there INR?
INR, no INR.
There must be INR. If you have PT, APT, you have to have INR as well. Most likely INR is unrecordable off the chart. So it's very, very severe. You can see the first reading when the patient arrived, platelet is thrombocytopenia, very severe, only 6, so worse than dengue fever. And total white count is raised. That's most likely due to leukocytosis, reactive leukocytosis, not secondary infection. And PTAPT is evident of coagulopathy. CK is not that high yet. I'm not sure whether this is correct, CK or not, but typically CK will be high as well with such tissue injury. So this doesn't make sense. Maybe you were writing a different CK. Creatine kinase creatinine kinase. Creatine kinase is different. So the LDH also liver enzymes raised. So this is the point where they give the antivenom. Even after 1 hour of antivenom, they still find the repeated blood after the first dose of antivenom. So that's why they decided to give the second dose of antivenom. You can see there's a marked difference already in the platelet count, the thrombocytopenia. But after the second dose, the coagulopathy seems to be returning back to normal. So this is how we interpret the response to the systemic envenomation from hematotoxic envenoming. Okay. So comment maybe, Hassan, you have a comment about this? What do you think?
After I have seen the progression of the case, yes, there is a kind of a clue. This is might be more leaning towards the hematotoxic rather than to be myotoxic. But still, that myotoxic things might be on board. But anyway, as you have pointed out, the CK is like kind of just normal. And that is like a bit not correlating with even the clinical picture of the two hands, which is like looks badly swollen and all these probably signs of tissue damage. But anyway, as I have said, the clinical scenario and projection like leaning towards the hematotoxicity. I just want to comment on the progression of the platelets. So within the same day, the platelets jump from 6 to 290. I'm not sure whether that is like kind of biologically possible.
Yeah, it's possible.
Unless this gentleman has been transfused with the
No.
platelets.
No blood transfusion.
No transfusion.
Yes.
Hmm.
So this is very interesting. So maybe JD wants to comment a bit before I give my last comment about that. What do you think of this progression? You think it's working or not working, the therapy that was given?
I think that it seems that I think is it correct that two antivenom, two cycles? You mean the first cycle was given?
Yeah, 2 cycles. Yeah. So after the first one, after 6 hours, and then they give another one after that. So there total of 6 vials.
Yeah, total of 6 vials.
Of Malay antibiotic antivenom, yes.
Yeah.
1 dose is 3 vials.
Yeah. Well, it seems that in the laboratory investigations that there could be some responses to the I think it's a monospecific antivenom, right?
Yes, it is.
Yeah, and I think the patient definitely had some consumptive coagulopathy, which was immediately reversed with the administration of antivenom. So usually for some hematotoxic snake bites, some would actually go into VICC, so venom-induced consumption coagulopathy, that could also decrease some platelet. But my question is that why maybe there could be some form of good supportive treatment in such a way that I think the CK is rather, I agree, maybe it's creatinine than creatinine kinase. So although
Kinase,
yeah, creatinine, although you can see that there's slight increase in the, I'm not so sure if this is really creatinine kinase or creatinine. Yeah, so I was just thinking that some complications would also have some form of acute kidney injury following hematotoxic envenomations. And my other comment is that although we usually do 20-minute whole blood clot test for academic purposes, but if you have already PT-PTT, I think it's no longer needed.
Yeah, so I think the 20-minute whole blood clotting test that done is just to give us the reassurance that the lab test was correct. Just it's a kind of a test positive,
we also do that for academic purposes. For us
because
to
it's the first reading.
Yes. Fastest reading.
First reading is yes. So yeah. Okay, Vanessa, any comment about these blood results?
So see a bit see different because I see that the coagulation disorder improve after you gave them antivenom. So does mean look like that we have the right. I mean that we identify the right snake, right? The right kind of snake by the patient because it's it improve very clear, right? But I see so surprised because after 5 hours, for the platelet is increased very from 6 to 294. So I'm so it's a surprise about that. But you said that no transfusion, right? No blood transfusion.
No. This is no transfusion. No.
Yeah, so this is I'm so surprised. After 5 hours, it's become normal to father. amount of platelet. Yeah. Just that.
Yeah.
So you don't show the ENR here.
I thought that is INR. INR, yeah. Must be INR in the.
Yeah, just now.
The INR was 2.36.
No, the first one?
The first one was not recorded. Only on the last day is 2.36.
Oh, the last is still, yeah. So it's still.
So it's low. Yeah, it was low in the beginning. Unrecorded, yeah. Unrecordable. Okay, so just to summary the results here again, this is typical. We have seen many times from Malayan pit viper. The earlier so-called response was thrombocytopenia, quite significant thrombocytopenia. I think this is made worse from the massage of the patient just now. So went to systemic envenoming quite drastically and caused thrombocytopenia with significant coagulopathy. So and we have experienced before, even after the first dose of antivenom, which is 3 vials for the Malayan pit viper, the thrombocytopenia is reversed almost to normal level. Typically, sometimes it takes 2 times, means that if like something is very severe, then we require a second dose. But for most of the cases, first dose is already sufficient to see improvement in the thrombocytopenia. This is because the envenoming is in the system and it's not in the liver. So if somebody has a good liver, it's still actually producing coagulating factors and also the platelet generation. If you remove the venom from the system, it will replenish back the counts within the 6 hours. Okay, very fast. And the second dose was given because it was continuing still to be having coagulopathy. So they said that the possible patient could benefit from the second dose. So that was given after second dose, and the next day is kind of back to normal. Okay, level. So anything else, moderators, you want to add on to this progress of this patient? So it shows if you give the appropriate antivenom to the appropriately diagnosed case, it can actually show a very good response. So that's why we have to monitor the patient closely to see these responses. If we do not see any response, then possibly either we are using the wrong antivenom or could be the wrong diagnosis as well. Okay, all right. Yeah, uricreatinine in the, yeah.
Was the patient?
So this part of the breakdown. Sorry?
Was the patient transfused with PAC-RBC?
No.
No transfusion as well.
No. The HB remain. I think he's an elderly patient, so he's an old gentleman, probably with some mild kidney injury as well. So that's why the creatinine urine slightly raised. On top of that, worsened with the tissue insults that we saw, plus his anemia from the age. So he was started with probably maybe low HB. The envenomation makes it a bit worse, but you can see the recovery back to the so-called like the basal level of 8 point something HP just now on the third day. Okay.
Prof. Kal, I just want to ask.
Yeah.
During the time of arrival, maybe a few hours after the antivenom, was he shown any sort of external bleed or internal bleed?
Yeah. That's
other than
bite
sites.
No, there was no other signs of internal bleeding or third space loss somewhere else. Yeah.
Thank you.
Yeah. So, I mean, that's a good point that you're making. Make sure that the other places, something severe like this, you have to consider all those things. Third space loss somewhere else, occult bleeding that we cannot see, especially in the abdomen or in the brain. But this, if that happens, usually the patient will present with also other external bleeding, such as from the nose, from the gums, so those will definitely worry you. That could be somewhere else. There's a bleeding. Yeah, but in this case, seems to be quite quickly responded to the antivenom. Okay, so patient progress, moderators.
All right, so move on to the patient progress. The bleeding from puncture wounds resolving. He developed hemorrhagic blister of fingers upon completion of the antivenom. Patient developed anaphylaxis after the first antivenom. Thus prolonged his administration. Developed persistent abdominal pain and become pallor and suspected internal bleeding at that time. Action was taken. Action at that time to give the second dose antivenom. Platelet concentrates transfusion. CT brain in view of the history of confused and inconsistent history. Otherwise, the finding was normal CT brain. Ultrasound find no free fluids and no hematoma. Thanks.
Yeah. So this is after the initial, right? That's because the initial finding, initial given of antivenom is before the platelet concentrate.
And then this the chart for snake bite chart. You can see on the right hand, it's improving, pain score resolving, and no tender lymph node. However, on the left side, left hand, on the left hand, you can see the RPP of +10. Otherwise, all's normal. This is the picture of patient post recovery. We'll proceed. Leave it to the panelists to discuss.
Yeah. So what do you think of the? Do you think the patient require platelet transfusion, Hassan? Oh, your mic is off.
Based on the trending of the platelets after the first and second antivenoms, I don't think that he necessarily needing to have a platelet transfusion as per now. Yeah, I don't think he needed.
Yeah, I agree with you. JD, anything in the progress? Can we go back one slide? Can we go back one slide? Yeah. One more? Just now? Yeah.
Yeah, actually, somewhat maybe in our setting here in the Philippines that we don't have antivenom in for our specific
hematotoxin, right? Yeah.
Actually, I might
so
keeping, but if you give platelet concentrate, sometimes it will actually induce more injury. You have more platelets to be consumed in the setting of your venom. So if you would have the monospecific antivenom for this case, and in this case it was actually available, then I don't think the platelet concentrate is also needed in this case.
Yeah, I agree with you.
But actually,
Vanessa, yeah, go ahead.
Have another comment. The patient had persistent abdominal pain and pallor, although focus. Is this the focus of the abdomen?
Yes.
Yeah, okay. I was also thinking Paulus. You might also monitor the pressure
yes.
swelling with your ultrasound. But okay, yeah.
Yeah. Okay, Vanessa, what do you think?
So I see you mentioned that the patient developed anaphylaxis because the patient have hypotension, bronchospasm after the first dose. After the first dose. So at that time, what did you do for that patient?
Then they gave the typical adrenaline, steroids, and also antihistamine. They reduced the rate of IV infusion of the CRAV, the antivenom.
Yeah,
so that's why it's called prolonged.
I mean that
Sorry,
for I mean that for antivenom at that time, you will be like decrease the rate.
Yeah, decrease the rate.
Right.
That's why the prolonged administration.
So
It takes
the
longer to finish.
administration, the longer.
Yeah.
But we still,
Yeah.
but we, I mean that we still do it at
We
the
still
same
repeat.
time with the
Yes.
adrenaline. Okay.
Yes. Yeah. So you can see even after so after the patient were given those therapy, patient recovered from the anaphylaxis, and they think that they want to give a second dose of antivenom. They give just the antivenom without any reaction after that. So it's very interesting, right? So it means that it's kind of a corrected from the first one. The second one we run as normal. It was okay. No need to repeat for adrenaline. Yeah. But I agree lah. The platelet is an overkill. I think the platelet is not really going to add on much from the patient's progress already, right? You can see. You can see also the bleeding. I think they give it because of the bleeding. So the bleeding kind of already halted. Just now you can see it's still oozing, but with this one after the antivenom and also they gave the platelet, the bleeding stops from the puncture wounds. You can see many puncture wounds and scratches on the limbs from the bite. So it's quite severe. Yeah, he's a lucky elderly man, I think.
I have
why
another.
the patient?
Sorry?
Yeah, but why the patient had developed persistent abdominal pain and become paler at that time because relate to the hypotension, relate to anaphylaxis or not?
Yeah, most likely it is from the anaphylaxis because they did the focus and there was no sign of blood in the abdomen. So it was more towards the anaphylaxis, I think. Yeah. So, okay. So any other last comments about this case? What do you think? Good
Actually,
case, not good case? What can we learn? Yes.
Hello.
Yeah, continue.
Sorry, I'm just curious. The patient had a history of anaphylaxis, and one of the treatments, although I'm not so sure if it's actually standard, there had been some cases I've read somewhere, although I had no experience, that some would actually give corticosteroids for those with venom-induced consumption coagulopathy with venom-induced thrombocytopenia. I'm actually thinking if the corticosteroids might have helped as well in the immediate increase of the thrombocytopenia. Maybe you have your experiences you can share, whether you can give for thrombocytopenia.
Yeah, no, we don't see that. We find that the appropriate antivenom itself is sufficient to just improve the thrombocytopenia, not the corticosteroids. So yeah. Okay. Right. Good question. Yeah. I think we learned a lot from this case. It shows also if you have a good healthcare system that can manage the patient well without that delay, patient doesn't need really major transfusion or even intubation or whatever. Just appropriate antivenom in the right time and right amount will definitely help. Further complication. Some people in the past thought that this patient might lose the limb might lose the limb from amputation and so on. But if you amputate this patient might die from bleeding. Even worse, surgical intervention. Yeah, or even people doing fasciotomy in the past. Yeah, but this patient recovered well, right? So any progression from this case, moderators? Yeah, so can see these are all ecchymosis from the envenomation.
I think ultimately.
So it's ecchymosis. It's more ecchymosis rather than necrosis.
Dr. Tal, I think ultimately the correct identification by the use of the gallery that you pointed in the history really correct identification of the snake and given the appropriate venom in this case.
Yes. Yeah,
It's very
but you have to bear in mind we didn't have the specimen to verify. So it's purely by patient's description. By right, we cannot use that as a diagnosis, but it can give us idea. Intelligent way to deduct, intelligent deduction of what is the most appropriate species for this case. So you have to know your species in your local area. So that will actually help you in guiding you in stocking the appropriate antivenom as well for such patients. Okay, all right. Anything else, moderators, for this case?
Yeah, Dr. Cal, I just want to
Yeah.
ask regarding the, yes, we kind of agree that platelet might not have much of role to play there, but in case if there is bleeding, would the PCC, for example, going to help much?
Yeah, I mean, if you have like severe bleeding, in terms of like not oozing, but you have profuse bleeding, and then you have third space bleeding and so on, we can give it concurrently, but not just platelet alone, because that will, as JD rightly pointed, will be consumed. If you give the venom, is still not is still present in the system. So you can give concurrently. For example, let's say patient has an intracranial bleed, right? For example, in this case can happen. Patient has intracranial bleed, you want to go into OT as soon as possible, right? So you can't wait for antivenom alone. So you can just give concurrent with the antivenom to perhaps facilitate the procedure in the OT, rather than patient just rely on the patient own body to replenish the platelet. You can give top up after you neutralize the venom in the body. So that's kind of a quick response to the thrombocytopenia that might happen prior to going to the OT. Yeah, but you cannot just give platelet alone because the venom is still there, right? It's kind of a no-brainer for that. So you need to neutralize, and then you top up while at the same time you want to intervene for the blood clot in the brain, for example. Yeah.
Probably
So I
I
think the
have
reason
one
why they
more.
give, yeah, sure.
Yeah, sorry. Probably I have one more. It might seem a bit outlandish, but I just want to ask, based on your experience with those kind of hematotoxic encounters, if there is any role for tranexamic acid.
Yeah. So we had issues also before with tranexamic acid because we don't feel that it is actually, if you have the right antivenom, we don't feel that it is necessary. We had cases where people use it, but we feel, if you understand the pathophysiology, why we use tranexamic acid is different from what envenomation is all about. So it doesn't mix in terms of the pathway for where it works. Okay, so it's about replenishing the profiles, the coag profiles, and also the coagulation factors, and also platelet. How does tranexamic acid work for bleeding?
Basically, tranexamic acid is like kind of antifibrinolysis. So if someone has ongoing bleed, so instead of just letting it bleed, whatever clots that you have, you might be keen to keep it intact. So that's why I thought of tranexamic acid.
Yeah. So in this case, not necessary, because if you notice as well, for coagulopathy, there's procoagulant and coagulant. The conversion of fibrin is not to the fibrinolysis. Is actually is from non-matured fibrinolysis. So that's why when we measure the D dimer, it might not be too high, because what you have is a breakdown product which is not matured. So yeah, in this case, I wouldn't say that it has any benefit, because the patient already responded well with the antivenom that we gave. Yeah. We had situation where somebody gave tranexamic, but we feel that it's not really necessary. Yeah. All right.
If thank you to the professor and all the panelists. Now we're done with our first case. We'll move on to the next case.
Okay, so for the next case, it's about a 1-year-old, 15 days old boy was bitten by a snake at night around 8:30 p.m. in Kedah. He was sleeping in the baby cot, which was at the floor during the event. He was bitten once on the right big toe and nothing was done to the affected part. Initially, the 11-year-old elder brother heard the boy was crying and he vomited 2 times before decided to call upon their parents who were working at Penang at that time. Only 3 children were at home. They get help from neighbors and was brought to ED by them. According to the neighbor, child was floppy when they arrived. The father checked CCTV to see what happened and saw a snake at home. Mother and few neighbors went back home and killed the snake while the father came to the ED. So when the patient was brought to the ED, he was unconscious with peripheral cyanosis, no pulse on arrival. CPR commenced 1 cycle. The child was intubated, ROSC after 1 cycle of CPR. On examinations, the patient was intubated and sedated. Pupil was 3/3 reactive with CRT of 2 seconds, good pulse volume, noted bruise with 2 fang mark on the right big toe. The vital signs was the blood pressure 121/83. The pulse rate was 150 and the temperature was 36.5 Celsius. The oxygen was 100 and under ventilator. The lungs was clear with equal air entry. Cardiovascular was dual rhythm, no murmur. Pre-abdominal was soft and non-tender. Okay, so for the right foot examinations, it was noted that there was a bruise and swelling seen over the right big toe, 2 fang marks seen just next to the bruise part, and the compartment was soft. The DPA and PTA was palpable, and there is also cold peripheries are noted. So these slides are showing that more clear pictures of the fang marks that you guys can see, and this is the picture of the snake. So I open up to the panelists to discuss about this case.
Okay, anybody wants to go first? So is this a bruising, or is it a bruising or not? Yes, Hassan.
Yeah. Again, the time frame wise is like quite short from 8 ish a.m. Until before the office hour time. Yes, I can see from the picture there's a bit of darkening of the skin, but I'm not sure whether that is like bruises or some skin crosses. But let's go back to the history. It seems to be, at least to me. I'm not that so much into, I have much of experience with this snake bite, but based on the history and based of on what I have read, probably pointing towards something neurological. I mean, neurotoxic kind of encounter. Probably this young boy, he was arrested because of some respiratory compromise. That's what I thought of. But as Dr. JD saying all the time, let's see how the progress later on. Yeah.
So JD, want to comment about this? What do you think? You're familiar also. This can happen in the Philippines.
This is actually our profile of snake bites that would be brought to the emergency department mostly. Although we don't have these kinds of snakes in the Philippines, I think of Naja yeah, Dr. Caldun, right?
Yes, correct, yes.
And the identification of the snake. So it's actually clear that based on the identification of the snake, and it actually concurs with the presentation of the snake, which would actually give you, I think it's both um, local and systemic envenomation. Systemic being there's actually neurotoxic presentation, seeing that the child was already floppy. But I'd just like to comment that um, perhaps the patient was immediately brought to the emergency department because after one cycle of CPR and resuscitation, ROSAS was achieved immediately. That's actually different in our case because sometimes our patients will really travel like 2, 3, 4 hours before they reach certain emergency departments. So I'm thankful that this patient may really benefit from the definitive treatment and if the patient was stabilized early on.
Yeah.
I think the swelling will continue to progress as I believe that Nadia Kaukia would have cytotoxic envenomation. There could be some form of necrosis. I'm not so
Yes.
sure. It's not really that clear.
So
Maybe, yeah.
can we see the picture again? The foot, please. Yeah, you can see there. Looks like bruising for the untrained eyes, but you are right that it's actually dermonecrosis, and it is actually already quite well formed when they arrive at the hospital. So it shows that the injury could be already quite some time already before this presentation where the picture is taken. Yeah, and you can see there's swelling as well, and the necrosis is progressing to the dorsum of the foot up to the ankle. So it could be quite extensive dermonecrosis as well. Okay. Okay, Vanessa, you have this species in Vietnam, right? Naja Kautia.
Yeah, yes. So
Can we see the
look,
snake, please?
yeah, but look at the, I mean, look at in the toe, the clinical of the patient. So we saw that the patient had local process already. So let's see, we can guess what kind of snake, maybe from nasal
Yeah,
species
yeah.
or something. Yeah, or clinical brand.
Yeah.
Because at first they don't know what is the kind of snake. But later when they show the picture, so yeah, so we can identify already. Yeah. But I think
Yeah, so
in clinical for the medical student, when you present the case, you should mention about. I mean, you describe about the how the patient breathe. I mean, respiratory because the patient
is the
have
patient
respiratory
breathing?
failure
Yeah.
or I mean, or a paralysis or wake or something. You should, I mean, to describe the sign symptom of that. In when you even when you examine the patient, you also need to pay attention about that.
Yeah.
Yeah.
Yeah. So it's very important when you have this type of envenomation. You correctly mentioned neurotoxicity, most likely postsynaptic blockade and causing muscle paralysis, so patient cannot breathe. So
Yes.
if you know the reason why the child might collapse is not because of the heart stop beating, but because of hypoxia. So if we can reverse the hypoxia early, as JD mentioned, the ROC can be very effective because what we need is just to introduce back oxygenation into the body, into the heart, so that the heart can already start beating again. So it's not about suppression of cardiac muscle, it's about oxygenation, right? So we can maintain the mechanical ventilation. The child can actually achieve ROSC quite rapidly. So in the children, their heart is very sensitive to oxygenation. So if we can provide oxygen to the heart can actually start beating quite rapidly, quite easily again. So hypoxia is the most common cause for asystole in children, right? Yeah. Okay, so it demonstrated here. You can they were doing the CPR. They did the CPR, ROSC achieved. But what anything else that worry us after the ROSC? What do you think, JD? Do we have a timeline when the child was found unconscious to arrive to hospital before ROSC? Moderators? Yeah. We don't know how long the child was not breathing, right?
Although I would surmise that it seems in the clinical course, in the local science it could be longer, but I think uh, I rarely see some patients already without. I mean, not given advanced airways with more than actually 3 hours or 4 hours. They will actually have shorter ROS. I would see
Yeah.
them with longer ROS, so usually more than 5, more than 6 epinephrines.
Yeah.
So
Yeah,
Okay.
I'm just
yeah,
thinking that shorter. I mean, the timeline. The patient was immediately brought to the emergency department.
Yes. But there was the delay, I think, from the time when the child was going for hypoxia until they arrived to hospital. That's why when arrived to hospital, it's already floppy and also asystole. Okay, but so what worry you? What anything that worries you after we achieve ROSC in this child?
No, but on the clinical in this is from local hospital or they transfer directly?
No, it's already a big hospital directly.
Oh, directly. Okay, so that means when the patient comes, so they have the patient have
CPR. Yeah.
CPR.
Intubated.
Yeah. Okay.
Yeah.
So that's
And
mean
achieve.
yeah. So I see that very clearly about the clinical side symptom already because the patient need the ventilator. So let's see respiratory failure already. So let's see paralysis.
Yeah. So anything else? Do you think the patient need antivenom or not? Okay, we haven't gone to the antivenom yet.
Definitely.
I think definitely this young boy he need antivenom. But the other thing is he might need to be intubated for a bit longer. So not sure how we can objectively kind of find out how the response to the antivenoms that we might going to give.
Right.
Yeah.
JD, you want to say anything about antivenom for this child?
Yeah,
What do you
actually,
think?
then I realized maybe there could be differences in the potency of the venoms. Our experiences in Naja philippinensis is that maybe within less than an hour after you have been bitten, you would really have you can actually go into into arrest within minutes. So that's actually where I'm thinking I'm speaking. Maybe this I don't know what would be the timeline the patient has been seen unresponsive when he was actually brought to the emergency department. But definitely this would actually warrant antivenom administration. We've seen some cases na after we give the antivenom immediately from uh, sedated, intubated, unresponsive. Sometimes they will label it as, oh, it's already brain dead. But after administration of antivenom, will really go back to GCS 11T immediately.
Yeah, so that's interesting you mentioned about GS Glasgow Coma Scale, GCS. But okay, but we will talk about it after this. Vanessa, what do you think? Antivenom?
Yes.
Okay, which antivenom you want to give?
Yeah. So in my experience in Chợ Hospital, so they will give the antivenom for this case. Yeah.
Right.
At first,
Okay. So
yeah. For this guy, so we have we have an antivenom made in Vietnam, so that's
Okay.
it. They will give them. They will give this patient immediately, I think.
Yeah, for the Cobra,
Yeah.
right? Cobra antivenom.
Yeah,
Yes. Okay.
Even the patient have a under ventilator, so they still give
Yes.
the patient.
Okay, that's very good. First, we deal with the ABC, and then we treat the cause, which is envenomation, which is with the appropriate antivenom, right? So this patient, I think, received the full dose of the Najacautia antivenom. Is it correct, moderators? Do we have any
Yes, Prof.
yeah, progression after that?
Certain depression.
Yeah, so these are the... Okay,
So for
go
the
ahead.
investigations, the food blood count was noted there is a high in white cell counts and also platelets. The creatine kinase also high, which is 183, and coagulation
It's not
profile was
creatinine
also
kinase,
prolonged.
it's creatine, right? Supposed to be
Yes,
creatine, not creatinine.
Yes,
Wrong
creatine
spelling.
kinase. And for coagulation profile also prolonged for PT and also APTT. Renal profile normal and liver function test only high on AST.
Okay. Okay.
So impressions on the ED that time, they revised the CPR secondary to systemic invasions by Naja Cautia species. Cardiac arrest secondary to systemic innervations by Naja Cautia species was done. Managements at ED, the patient was given Naja Cautia antivenoms, 10 vials in active 4 cc, IV vitamin K 2.5 mg, IV augmentin 252 mg, IV midazolam 3 cc, IVI fentanyl 2 cc per hour. Partisans every 30 minutes was taken. IVD 35 cc was given of normal saline D5, and also the patient was transferred to the PICU.
Okay, JD, you want to comment? Anything you want to ask? Go back once. Go back, please.
Yeah.
Go back one slide, please. Okay. So what do you think?
I'm not so sure if the vitamin K is actually necessary.
Yes, exactly.
One.
Yes,
Number
I also
Why?
have the same question. Why they give the vitamin K here?
Yes, yeah.
Number two.
I don't know. I have no idea why they give actually. So I had the same question, why they give vitamin K. But I think they saw maybe the coagulopathy, the INR maybe raised a little bit. Can you look at the blood results? Yeah, the platelet was high. No INR. INR 1.4. I don't know whether that's the reason why they give. Okay, so actually we see in Cobra envenoming in Malaysia, there is actually some element of coagulopathy as well, but it's not that high as the pit vipers. So you might get a slightly raised INR, you might get a slightly deranged PT, APTT, but it's not to the level of where we need really antivenom for it. But you can see here the WCC white cell count is high also in the initial. So that's also another sign of reactive leukocytosis. Okay. Yeah, it's not creatinine kinase. We don't look at creatinine kinase. We look at creatine kinase, CK. So renal profile you can see, but what we worry about is also the potassium. If it is some element of cytolytic activity, like hemolysis, for example, but you can see the HP was okay. So the potassium is also normal. Okay, that's all that I can say, but I don't see why vitamin K is necessary for this child. So we asked the same question. Okay.
I
Yeah.
have another observation,
So, okay.
Dr.
Yeah.
I'm not so sure if the patient was continuously sedated at this point, because we also monitor the response to antivenom treatment.
Yeah. Okay. So kalau you tengok the next page, can we see the next page of the progress? So you can see that the patient is on the fentanyl and midazolam. So they continuously so-called like brain protect the child until the child was in the PICU. So your question just now, how do we then examine to the response from the antivenom that we gave, whether it's working or not? So the only way to know is through the motor response, the reversal of that, right? So we have given the antivenom in emergency department, but we did not stay for 6 hours to review the response. So the child was in PICU and already ventilated, mechanical. So what they did was we advised them to withhold the sedation for at least 30 minutes to 1 hour, and try and see the response, motor response in terms of ventilatory response. You see that they are monitoring the ventilation, right? So is there any active ventilation going on with the child, or any other muscle movement? And we don't use pain for checking the muscle response, motor response. We use verbal and tactile. So that is actually the child might be unable to move, as you correctly say. The GCS will not actually help, actually give a false impression about the child mental state. So the brain is still working, but the muscle is still not sort of like reverse in terms of the paralysis. So GCS has no value in assessing this child in this stage. So what we suggested was one more worry that we had was actually explained to in the next slide. Okay, go to the next slide. Moderator? Yes.
So currently for the patient's progress, the patient's vital signs are stable without inotrope support, on low ventilator settings, no CT brain was done, and currently on cerebral protections.
Okay, next. Okay, so what worried me in the first instant when the child arrived was about the brain, because we don't know how long the child was hypoxic and asystole before we reverse. So what worried me is about the HIA, the hypoxic injury to the brain. So that's why we asked them to do CT brain. So early CT brain will not help because you will not see any hypoxic changes in the brain. You see more than 6 hours, then only it may appear. So in this case, the child was still under observation, and they proceed with I think MRI, if I'm not mistaken, and there were signs of cerebral edema and also hypoxic injury to the brain. So it's not really a good prognosis for this child. He may not, the child may reverse from the envenoming, but the insult to the brain is perhaps will not be actually reversible. And that's the thing. So it's just a supportive therapy at the moment to hope to bring down the edema and so on. So we don't know what's the outcome of this child yet. It's still ongoing. Okay. Yeah. Hope for the best. So we will not actually required to how should I say top up the antivenom at this stage, because what we see from the injury did not progress further. The necrosis, everything is already static. Swelling or static, RNR is not progressing. So there's no rule for antivenom, for top-up antivenom in this child. Okay. Yeah. So this is the worry that we always have. Somebody came with asystole for post envenomation. We always worry about the brain. It's not so much about the envenoming itself. We can reverse the envenoming, but we can't reverse the brain injury for somebody who has, hypoxia like this. Yeah, it's a sad story in a way. Okay, any last comment from JD, Hassan, and Vanessa?
I just want to share an experience to your student. Because just in my experience, when my patient told me about the whole story when he went in the hospital after the nasal care bite him, and he told me that before he developed to respiratory failure, he started feel like weak already, but this is impressive to him. This is very pain about the pain when the nasal bite.
Yeah.
So he told me that actually it's super super painful.
Yes.
At the bite. Yeah. So but
Yes.
when he asked for the doctor give him the antivenom, but doctor still say no. Until we will give until the patient have respiratory failure or paralysis. But he said that he said that because he feel very painful, and also become more weaker. But he asked me that if they give him the antivenom earlier, so maybe the pain will be decreased or not. So in your opinion,
Yes.
how do you think?
Yeah. Yeah. So the pain we find is also one of, that's why if you notice one of our parameter that we measure is the pain score progression. So antivenom will definitely also reduce the pain. We find this often, and we measure the pain before giving antivenom, halfway of giving antivenom, and also after completion of the antivenom. And we find there's actually reduction in pain score for patient. So after antivenom, so antivenom does help with pain, but I think in this situation, the pain for this patient, you can start off with analgesia as well for that patient. If it is still intractable pain, then you may consider initiating. But you have to look at other parameters as well, of course, before giving antivenom.
Yeah, but for
there must
that
be something that is he having like necrosis and so on as well. So if he has, then that is a sign of giving antivenom also.
But for that institution, for example, if the patient come to your hospital, but the patient have not the respiratory failure yet, but you know, or you identify already that's the nasal species, so the patient maybe have the respiratory failure or paralysis later. So at that time, you still give them the antivenom, or you will wait until the patient have a respiratory failure.
No, we don't just wait until respiratory failure. That's a bit too late as well, right? But that is appropriate response. But we see the early sign of neurotoxicity is not respiratory failure. Early sign will be ptosis. So that's why your clinical observation of the patient is to identify ptosis first. Any other difficulties, speech, it doesn't say we stop breathing.
But I mean,
so we
for example, if the patient come to the hospital early after bite, for example, it's early, but it still have not the toxic, right?
Systemic. You don't have the
failure.
systemic neuropathy.
Yeah, for example,
we don't give
just because that's in my patient, he know, because he is the expert in snack. So let's say he know what kind of snack just by him, and he know already, and he run to the hospital immediately. But he wished antivenom, but the doctor say no, still wait. If you have a respiratory failure, or they will give antivenom. No. If not, they don't give that.
The reason the doctor gave is wrong, but the reason why the doctor did not give is correct. So all is correct. There's no indication to give antivenom. There are indications to give antivenom. You have to understand that. There are indications to give antivenom. When the person comes with just a bite, doesn't mean that you will go into systemic envenoming. We had many cases where just a local bite, local symptoms only did not go into systemic envenoming. So why you want to give antivenom? So that's why we have to observe the patient closely for early signs of neurotoxicity, which is a sign of systemic envenoming. Then only we give the antivenom. Okay. For pain, you can give analgesia. There's no issue. Okay, but if there is the more necrosis and it is involving the digit, for example, causing swelling, there is already a sign of local signs for local envenoming that indicates for antivenom. So you have to have very clear understanding what is the indications to give antivenom. So we cannot respond to, I want antivenom, doctor. You cannot give antivenom to that patient just from the request of the patient, even though he's an expert of snakes, right? But he's not the expert of envenoming. Yeah, we are the experts of envenoming, so we have to be, yeah.
Okay.
But the reason why the doctor say you cannot get antivenom because you don't have respiratory failure is wrong. That is too late already.
Yes, he has other symptoms already, like a little necrosis. He feel very painful.
Yes.
And progress is like more severe.
Swelling.
But
That's why we do the So those things have to come into play. I mean, you have to be clear what the indications are, the progression of the symptoms, both local and systemic, before respiratory failure develop. The respiratory failure is already quite late. So in this child, it's late already.
Yeah,
So,
yes.
yeah. So that's the most important to understand how we manage patient. Not just snake bite, Najah Kautia, straight away give antivenom. This is just, I think, it's not appropriate lah. Okay, Hassan, last comment about this case before we perhaps we don't have time for another case, do we? We'll see. Your mic is off. Microphone. We can't hear you.
Sorry.
Your mic. Okay.
Yeah, sorry. From ED perspective, let's say this child came to us, still he can breathe by his own, but we do note that he has signs of neuroinflammation. I'm not sure. Would you prefer any type of sorry, not neuro, it's like muscle paralysis, whether to go for depolarizing, depolarizing, or you can just skip it all and we can go for, let's say, awake intubation? Because we do have such dilemma a few years ago, and we don't know what to choose.
JD?
Well, actually, we just go ahead with awake intubation. Anyways, there's to begin with, and there will be not much reflex that can occur. My only comments about it is that we had some experiences that even though the patient is in a lock-in state, after administration of antivenom, the patient will actually really regain consciousness, and the intubation can be actually immediately weaned, actually. So those are actually some of our experiences.
Okay, right. Okay, so do we have a quick case after this? One more, just in case.
Prof, before we proceed to the next case, there is a questions from a student.
Yes.
So, okay, from the students, she asks if there is, she heard that there is some people from our community, usually that make a tight bandage around the affected site to prevent the venom from spreading to other body parts after being stung or bite. Is this practice medically correct or not? And or will it be dangerous since it may obstruct blood flow to the affected site?
Panelists, anybody wants to answer this?
At least for this case, if the bite has been identified early on, some of the guidelines and even actually the WHO guidelines for Southeast Asia will really recommend application of pressure bandage immobilization for cobra bites. So of course that could be different if there's already extensive swelling. But in this case, I would rather put the pressure bandage immobilization early on when the kids saw, although they're 11 years old in their child, but immediately you would actually, the logic is that you would actually retard the lymphatic transfer of the baby, not tourniquet.
Okay. I wouldn't put even the bandage immobilization. I would just immobilize the limb. The reason being there is already swelling and also cytotoxic effect. So we don't put PPI for this patient. We just immobilize is sufficient. Okay.
Maybe
So
early,
obviously tourniquet has no value
early on, yes.
for this case.
I'm talking about
Yeah.
that early on in the, but in this case, there's already swelling, so it's really difficult for it to be bandaged.
Yeah. So yes. Okay. Last question, last session, last case, I think. Before we
Yeah,
go.
we have a quick case here. A 72-year-old with underlying hypertension alleged tarantula bite at 9:30 p.m. in Sarawak. The alleged tarantula bite was over right medial side of left index finger once while she trying to wear her shoes as the spider was inside the shoes. Post-trauma, she sustained pain with pain score of 3 that associated with minimal bleeding over the bite side. She subsequently pinched the bite side and massaged the bite area with minyak kapak. Next. On physical examination, GCS was full, able to walk, not tachypneic, no facial asymmetry or ptosis noted, power limbs full. There was a tingling sensation over left index finger, full range of motion over all fingers and left wrist, minimal redness over left index finger, no swelling, no active bleed and no necrosis. Noted a 1 bite mark over medial side of left index finger. Vital signs, BP, pulse rate, and respiratory O2, temperature all was normal. This is the picture of the bite as we can see on, hope you can see on the index finger, medially we can see there is a bite mark there. This is just another the same picture, and this is the picture of the spider that was killed. Next. So investigation at that time, only FBC were done. However, the result were normal, and other investigations still pending at that time of the impression. This is a tarantula species bite. Management at this time was only they only give IM and ATT and tablet PCM. Patient progress, no swelling or necrosis of a bite site. Vitals were stable and discharge subsequently was discharged. So now I leave it to the panelists to discuss any regarding this case.
Can we see the bite side? Yeah, okay. Can we see the bite side? Okay, okay. Vanessa, JD, Hassan, comments? Have you seen
myself? I have a zero encounter with the tarantula.
Well, it's very close to you in Brunei. It's just next door to Sarawak.
Yes, correct. Yeah,
you probably
we
have
don't
the
have
species as well.
Yeah, we don't have the clinical encounter with it.
Okay. So how would you manage, JD?
Interesting. I just had a referral of a tarantula bite this morning.
We read your mind. Okay.
Yeah, and this case popped up. So maybe from my experience, our tarantulas here would only cause local signs of envenomation, maybe minimal swelling to at least or even pain. But what is actually more bothering is the hairs that would actually elicit allergic-like reactions. So, yeah, that's my
What would you
comment.
advise if you, Vanessa, tarantula is quite a nice delicacy in Vietnam, I think. People eat tarantula, right? Deep fry.
Yeah, I don't have any experience on this kind. Yeah, so really, I rarely see the case in Vietnam for the tarantula bite. So I don't have any experience.
Okay. So it's just local, but when looking at this picture, what first thing comes to your mind?
Where is the bite? Is this the black
On
one?
the yeah, the black 2 dots on the index finger.
Eh,
To me,
I
it
thought
looks like a
Yeah,
snake
but
bite.
I thought it was
no, it was a what?
a mole. It's a nevus, a mole, a nevus.
Yeah, no, it's not anymore. But when you see this in emergency department after a bite, what worry you? What worries you? What's glaringly? What would be your advice to your juniors?
You have to remove the ring.
Remove the the
Yes,
ring.
remove the ring. Oh my God, you know.
Eh,
So those are the most important thing I think to be learned from this case. Please remove the ring and jewelry from the bite limb, the bitten limb, right? Yeah. So before it's too late. Okay. So again, it's just management is conservative. In Malaysia so far, our spiders are not deadly to human, but we have species here with the brown widow spider and also several other brown recluse spider, which may cause tissue necrosis, lysis. But so far no death that we have encountered that we know of. Okay, so treatment is just symptomatic syndrome based on if there's pain, give analgesia. If there is a secondary infection, then we give antibiotics, of course, with culture. Right. So I think that's all for the discussion. What is next in our agenda? Or do you have any other final say, Vanessa?
Dr.
No?
Calvin,
No.
Yeah.
I'd just like to
GD.
ask, in the previous case, our previous snake bite case, I saw that the patient has been given IV coamoxiclav, augmentin. So perhaps after the administration of antivenom, I expect that the swelling will not progress. Although,
Okay.
if there are actually signs of progressing tissue damage, then I would actually also continue antibiotic administration. So it's not actually universally given to all snake bites. That's what I'm trying to
Yes.
say. Secondly, I don't think that the IV augmentin will actually also cover for the species that would be seen for snake bite cases. So
Yeah.
mostly some of the species that would be seen would include I think Enterococcus and Morganella and some of the usual skin bacteria. So
Yeah.
maybe
True.
that's actually
So
my
yeah, so they're just starting with the broad spectrum first, and then they have to look at the culture of the blood culture of this. And I agree, most of the time that we get culture positive will be Morganella, Morganii, and Enterococcus. Yeah.
Although, Percal, what I'm saying is that I think their empiric treatment for antibiotic is not enough. Sometimes you would start using
Yeah.
Imperial Tazobactam, or they combine augmentin with another
Yeah.
fluoroquinolone.
Yeah. Yep. Agree. Okay.
That's it.
So can we finish or end the session?
Sure, Prof. Thank you everyone for all your thoughts and questions, and thank you to our panelists for your fruitful comments and inputs. Next up, we have prepared a quiz with a special prize for the winner. Please scan the QR code or key in the pin in Kahoot to play. At the end of the quiz, we will display the QR code and link for the e-certificate, so stay tuned.
Okay. We can start now. So since most of us today cases are snake bites, so we will try and answer this on snake-related injuries. Okay. Okay, let's start. Okay, let's see who's the winner. Number 3, Karish. Number 2, Miku. And the champion, Ed or Ed, I'm not sure, but okay. So congratulations, Ed. Can you give your details to our moderators so that we can give you the prize for today? Okay. Okay. Thank you. Back to our moderators.
Okay, now we move on to closing remarks. So first, congratulations and well done everyone for your effort. To the winner, please reach out to any of our secretariats. Can leave your name in the chat box and leave your details. Now we move on to the closing remarks. So for our closing remarks, please join me in welcoming back Dr. JD Comandante. Without further ado, Dr. JD, the mic is yours.
Thank you very much for your kind introduction. And I would like to thank and congratulate the organizers for this very successful activity. And again, for the second time, Dr. Cal, I've been always supportive of this activity. And I always ask myself and even ask the students present here, is clinical toxinology relevant for medical students? And I believe you already had the answers with the case discussion that we had. I would just like to share the highlights of why is it not only relevant for medical students but also relevant for all physicians, because our experiences here in the Philippines, snake bite is really one of our neglected tropical diseases. And you would know that snake bites, although UKM is not technically in the rural setting, we see a lot of them in the urban setting. More other envenomations such as your jellyfish, which is actually more neglected than neglected. So your role in understanding some of the concepts in toxinology, as you've seen in this webinar, will be the start. And hopefully, you will also participate and champion in building and like treating these kinds of diseases appropriately, focusing on appropriate safety and health-seeking behaviors in our patients. So again, with that, I congratulate everyone. Thank you for our panelists, Dr. Nguyen and Dr. Hassan, for of course myself. Thank you. So pat on the back. So thank you, Dr. Khaldun, for this opportunity that you have given us, and we're looking for another volume of clinical toxinology. Is it ready for medical?
Fourth episode. Yes. Thank you.
Thank you, Dr. JD Comandante, for this speech. And once again, thank you so much to Dr. Hassan Adam, Dr. Vanessa Uyin, and also Dr. JD Comandante and Associate Prof. Khaldun. It was an eye-opener to hear from the view of experts. We will display the QR code and link for the e-cert, so stay tuned. Congratulations and well done everyone for your effort. We hope this webinar, Q&A sessions and the quiz, the medical students in the attendance managed to grab some concepts. Thank you everyone.
Thank you.
Thank you all. Thank you all.
Thank you.
See you in the next
Thank you.
volume 4. Sorry, episode 4.
Thank you. Terima kasih.
Bye-bye, Emily.
Terima kasih doktor.